Good evening, ladies and gentlemen. We warmly welcome you all to the webinar on interstitial lung diseases on behalf of the Sri Lanka College of Pulmonologists. This webinar is organized by Interstitial Lung Disease Assembly of the Sri Lanka College of Pulmonologists. Today, we are lucky to have some international experts from US and UK, as well as our own experts to talk on interstitial lung diseases, which is a very important topic these days, especially in the post-COVID era. Firstly, I would like to introduce my co-moderator, Dr. Amita Fernandu, Senior Consultant Respiratory Physician, National Hospital Sri Lanka and Colombo Chest Clinic. He is currently the chair of the Interstitial Lung Disease Assembly of Sri Lanka College of Pulmonologists. He will do a brief introduction as well as introduction of the first speaker, Dr. Emily Fraser. Over to you, sir.
Thank you, Bodhika. Good evening and a warm welcome to all our foreign experts who have joined us and online participants. The ILD Assembly of the Sri Lanka College of Pulmonologists is very young, very recently formed. It was formed with the aim of fostering knowledge about interstitial lung diseases, sharing knowledge and experiences and expertise, and also standardizing diagnostic protocols and diagnostic pathways. We also aim to promote a multidisciplinary approach to interstitial lung disease, formulate regional and national expert panels, and move towards interstitial lung disease registries, disease-specific registries for connective tissue diseases in which we have a fair burden, and also hypersensitive pneumonitis and idiopathic pulmonary fibrosis. And now we are dealing with the challenge of post-COVID lung diseases. We also hope to liaise with allied professionals in our country and overseas and join societies, like-minded societies, so that we can share our experiences and gain from expertise of already established groups. So it's my pleasure and privilege to introduce our first speaker, Dr. Emily Ruth Fraser. Dr. Fraser, MRCP, Respiratory Medicine, PhD, is a consultant in respiratory medicine and interstitial lung disease, Oxford University Hospitals, NHS Trust. She's also clinical lead in the Oxford post-COVID assessment clinic. Her research interest is in ILD, idiopathic pulmonary fibrosis in particular. She also has extensive publications and research in a broad spectrum of interstitial lung disease. She is co-investigator for the post-hospital COVID study and the NIHR-funded breathlessness in the post-COVID patient, diagnosing breathlessness in the post-COVID patient. So she brings in a lot of experience, and we very much look forward to listening to Dr. Fraser on a talk on her topic of post-COVID ILD. Over to you, Dr. Fraser.
Hi there. Thanks very much for the introduction. Right, let me just share my screen. Here we are. Okay. Can everybody see that okay? I presume that's a yes. I can't hear anything. So thanks so much for the introduction. Yeah, so I have a subspecialty interest in interstitial lung disease, and my PhD was on idiopathic pulmonary fibrosis. I was particularly interested in following up our patients with COVID, particularly those that were sick due to the worries about the kind of interstitial lung abnormalities that would potentially persist afterwards. So during this talk, I'm just going to talk about the potential outcomes that we're seeing from COVID-19 pneumonia, so the radiological findings. It'll be interesting to look at some of the outcome studies that are coming out internationally, the risk factors for getting persisting lung abnormalities, some of the potential treatments and clinical trials, and then just lastly, having a look at some of the pandemic SARS 2003 data. There is a 15-year follow-up study just to get an idea of potentially what might be coming our way. So during the first wave of the pandemic, there was understandable concern amongst respiratory physicians worldwide, and particularly ILD physicians, about the longer term sequelae. So we know that when you come into hospital with COVID, you generally have an organizing pneumonia picture, and in more severe cases, this can tip into ARDS. both of these conditions, due to other causes, can lead to long-term lung scarring. And we know that in even idiopathic causes of pulmonary, of organized pneumonia, about a quarter go on to develop a fibrotic picture. So there were several different outcomes that could arise from having bad COVID or having COVID needing hospital admission pneumonia. And that was that essentially the lung would heal normally and we see complete resolution of the infiltrates, that we would get healing, but there would still be some persisting lung abnormalities. But actually, when we did lung function or see the patient clinically, they're probably of very little clinical significance. And then there's also the worry that we'd see scarring within the areas of organized pneumonia, and therefore, depending on how severe the acute infection was, would correlate with how bad the subsequent scarring would be afterwards. And then there was also this other risk and worry, and there was a bit of publication around that about the fact that COVID might trigger a whole new interstitial disease process. And although that seems potentially a little bit far-fetched, there was rationale behind that. And that was based on the fact that we recognise that viruses may well be cofactors in the development of the precipitation of something like idiopathic pulmonary fibrosis. So herpes has often been found to co-localize within fibrotic tissue, although cause and effect is obviously very hard to actually demonstrate. There's also autoantibodies that were being identified again early on in the first wave of the pandemic that had certainly overlap with ILD, connective tissue disease antibodies. So essentially what we're seeing is very much the first three. Unfortunately, what we're not seeing is much of the last one or any of the last one. So we get a whole range of recovery, resolution. So for example, this gentleman in December 2020, as you can see, really widespread infiltrates, severe disease, was touch and go for a good while. But by March 2021, they're pretty much resolved. There is still, the faint footprint, but actually really good outcome. And he did really, really well. And then, for example, there's this patient here who's an older patient. Although the changes acutely aren't dramatic, they're not that widespread, that they're there and they're quite plentiful. And this guy was about in his early 80s, he had comorbidities, and he again struggled. He was on our unit for several weeks needing CPAP and high flow oxygen. And then 6 months later, you can see that there's been a lot of improvement. The ground glass changes, the kind of areas of more dense airspace of pacification have pretty much gone, but yet there is still quite a diffuse abnormality that's remaining. You can see here a lot of kind of parenchymal bands. You can see some traction bronchial dilatation, reticulation peripherally. So he didn't do quite so well. And then there's this gentleman here again who has the classic, acute COVID changes, so the bilateral, subpleural, peripheral, consolidative changes. And interestingly, although this was during the acute phase, you can see this bronchi that looks rather dilated and doesn't taper towards the periphery. That makes you a little bit worried that well could be kind of traction bronchiectasis developing in that area. Clearly, it's hard when you have dense airspace of pacification to be sure of that. And often we overestimate the amount of fibrosis in the acute setting. And actually, those bronchi start to look more normal as the acute changes resolve. But then 11 months later, so almost a year later, you can see it remains tapered towards the periphery. And similarly, in the area of dense airspace of pacification, you can see now traction bronchial dilatation, reticulation. So certainly the hallmark of having had COVID with fibrotic sequelae. What you're not seeing is an area of abnormal tissue outside the areas of acute abnormality. Essentially, what we're not seeing is a progressive picture. So just briefly talking about a few outcome studies that have been published. So this was an early one that was done 3 months after patients were discharged from hospitals by a Canadian group, and they were specifically focusing on respiratory outcomes. And so the headlines here are that 88% of patients at 3 months had persisting abnormalities on their CT scan, and over half had one abnormal lung function parameter still. And then what the authors did is they tried to work out what would predict persisting lung function in CT abnormalities. And what they found was that the days on supplementary oxygen was a positive correlate. And again, that's not really surprising because essentially the amount of time you need on oxygen is probably a kind of surrogate for how severe the disease was. I think this table is really interesting. This is the same study. So although 88% of patients had persisting abnormalities at 3 months, if you ask them a question of as to whether or not they're breathless, only 1 in 5, 20% of people are still breathless. So there is a discrepancy there. 60% is within normal range, and we've got an average of 77%. It's not horrendous, and clearly we've got a range of of abnormalities here and in severity to begin with, but still it's not too bad. And most importantly, their 6-minute walk test, so kind of a really good marker of kind of how well they're doing physiologically, is normal with a kind of an average of 96% or predicted. So although there are abnormalities, patients functionally haven't been doing too badly, at least according to this study of 60 patients. And then there was this larger study that looked at outcomes from 6 months. So this was from Wuhan. This was a large cohort study of 1,733 patients. And it looks at patients who've been hospitalized with COVID, all degrees of severity, from just needing nasal prongs to actually being in intensive care, and looking at the outcomes at 6 months. And as you can see from the very top, over 3/4 or so of patients do report a symptom. So they are a symptomatic group of people at 6 months. But then when you look at the type of symptoms they're having, fatigue and muscle weakness, pipistrellus is the most common, sleep difficulties, hair loss, essentially symptoms that we commonly see in patients that have been acutely unwell, particularly people who have been in ICUs, the post-ICU syndrome. Interestingly, down the bottom, they've looked at breathlessness score using the MRC dyspnea score, and what they've reported is around 1/4 of patients have a score of greater than 0, i.e. will have a degree of breathlessness. So again, although they may have persisting lung abnormalities, the majority of patients aren't breathless. They have fatigue as more of a problem in this one study. Large study. And this is another study that is very optimistic. I'm not sure if it really, but this looks at respiratory outcomes in 60 patients over a year. So it follows them through at 3, 6, 9, and 12 months. And as you can see at 3 months, the majority, so this is a dyspnea score, this is an MRC dyspnea score. And as you can see, the majority of patients are breathless. They've got a score of 1 or 2. A few of them are no longer breathless. At 6 months, it's better. At 9 months, it's even better. And by a year, 95% of patients are no longer breathless. And similarly, looking at the 6-minute walk distance, this beautifully increases over time to the point of normality at 1 year. So these patients also had CT scans, and what the investigators did was scored the abnormalities. So they looked at ground glass opacification, they looked at consolidation, they looked at parenchymal bands, and various other factors, and they score them at the percentage of the lung area. And again, this lovely kind of decrease in values and percentage of abnormality of the lung area over the period of the year. So the blue lines indicate all the patients who have normalized their CT, whereas the red, they still have some persisting abnormality. But again, what's important to note is that most patients, the amount of abnormality was less than 10%. Now, the reason why I say that I don't know how kind of extrapolatable this is to our cohort, our general cohort of patients that we see, is that the authors in the demographic data state that not a single one of them had ever smoked, and none of them had any comorbidities. And so that doesn't really reflect often what we see through the ICU and the HDU. So risk factors, and they have been identified. So we know, unsurprisingly, if you have severe COVID pneumonia, you're more likely to have persisting lung abnormalities and potentially lung fibrosis. Male gender, older age, smoking history, comorbidities, essentially the same demographic risk factors that present for idiopathic pulmonary fibrosis. And interestingly, there was a study that looked at telomere length in leukocytes 4 months after hospital discharge. And what they found was that patients that had fibrotic sequelae on their CT scans had a correlation with shortened telomeres. And again, that goes with the kind of pathogenesis of idiopathic pulmonary fibrosis, the aging lung, the kind of lack of the compromisation of kind of repair mechanisms as the lung ages over time. CRP and IL-6 in one study also were found, and the higher the level, the more likely to have interstitial lung abnormalities. And again, that may go with severity of lung injury. So treatment, what do we do? Well, we don't know. We don't know what to give, we don't know when to give and for how long to give. But I think it's helpful to look at it in 2 slightly different ways. So look at the inflammatory kind of post-acute stage, and then obviously the fibrosis stage, or rather the fibrosis side of things. The important question is when the fibrosis occurs, and whether or not inflammatory lesions that we see then evolve into fibrotic lesions. And so this is a patient who is in a hospital, has been with us for quite a while, and is in that slightly kind of post-acute stage, but still requiring a high degree of oxygen and is still unwell. And as you can see here, widespread airspace opacification and what looks to be a kind of dilated bronchi kind of appearing here. And actually that is what we're seeing quite often, that within these areas of consolidation, there does appear to be fibrosis forming earlier on rather than later on. So generally within ILD, as everyone I'm sure is aware, we worry about these inflammatory lesions, so a cellular NSIP, for example, evolving into a fibrotic picture. So inflammation healing with more fibrosis, and the idea being that if you curb the inflammatory process, you will halt the development of fibrosis. And so therefore, if we've got fibrosis early on in the disease course, then maybe we need to be thinking about treatment at that stage. And that just shows, sorry, the picture of it closer up with the sacculated bronchi. And I think that's quite important to note. So as I said, we quite often overestimate the amount of traction bronchial dilatation, but when you get this kind of like irregularities, it does suggest that you've got kind of contraction of the lung parenchyma splinting apart the airway. So the role of steroids in that post-acute period. So this is looking at the inflammatory side of things. So this is after they've had dexamethasone, they've been in hospital for a few weeks, we're stuck on oxygen, they've still got widespread infiltrate, and then we had to think, what do we do? And actually, I think there's a lot of anecdotal evidence, there may even be a little bit of trial data, I haven't seen it, that kind of suggests that steroids can be helpful. And certainly, you know, we do give them. So for example, this was a gentleman who'd been unwell for 3 months. You can see a really abnormal, 3 weeks, sorry, a really abnormal chest x-ray. He was on wall CPAP. He was on, had an FiO2 of 100% of 1. His infection markers were low, been treated with broad spectrum antibiotics, and we were just stuck. So he bit the billet, he was diabetic, he was hugely overweight, but we gave him prednisolone. And within 5 days, this is the radiological appearances, his oxygen requirement had gone down to 0.4, he was on machine CPAP, and in 2 weeks, there has been a really good radiological improvement, and he was on 2 liters nasal oxygen and then discharged a few days later on nothing. So that does suggest that there is a role here for steroids. Has that reduced potentially the development of fibrosis? Well, we don't know. And what's the other evidence? So this is slightly moving on a little bit. So this is outside that kind of post-acute setting when they're still on oxygen. These are patients who are back at home and who are struggling. So this study was an observational study that came out of Guy's and St Thomas's, and they had a large cohort of patients, again from the first wave. I think there were over 800 who had a telephone call at 6 to 8 weeks. And those who still had a lot of breathlessness then came in for a CT scan and had lung function tests. Those that had inflammation that persisted on their CT scan and had deranged or rather low gas transfer and FVC were offered a tapering course of steroids. And in the end, I think there was only about 30 odd patients that were given this. So they're giving a tapering course of steroids over 6 weeks. And what you can see is that gas transfer and the SVC do indeed improve. Now, there was no placebo group. And as we can see, I'll show you in a minute, we quite often find that actually over time, things are improving. There's also this study here that looked at the role of potentially high dose versus low dose prednisolone in symptomatic patients who'd been discharged from hospital with COVID-19 and had diffuse inflammatory parenchymal abnormalities. So they used very similar score criteria to the previous study. And what they did is they gave either a 40 milligram tapering course over 6 weeks or a much lower course of 10 milligrams over 6 weeks. And what the authors were looking for was radiological improvement, symptomatic improvement, improvement in their lung function values, oxygenation. And actually what they found was that everybody got better, or most people got better, and there were no differences between the low and high dose group. However, again, there was no placebo group. And so again, more anecdotal data here. So this was a patient who I saw who'd been really sick with COVID. She was a 6-year-old lady who'd been in intensive care. And so this is her acute CT scan. It was complicated by pulmonary emboli. And then I saw her in clinic at 3 months. And she has, as you can see, a lot of abnormality that's persisting. So we don't have the dense consolidation there, but we certainly have a fair amount of ground glass change. And with that, we have areas of reticulation and traction bronchiectasis. And so again, going back to kind of what we would normally do in the context of an inflammatory and fibrotic interstitial lung disease, well, we treat the inflammatory component and see whether or not that helps halt the fibrotic component. She had a markedly impaired gas transfer. And so we did discuss steroids, although she wasn't keen. She said, actually, you know what, I'm doing all right. I don't want them. I don't want the complications. I said, fine. And so what we did is we just opted to review her again at 6 months, repeated her lung function. And at this point, she was walking 6 miles. Her FVC and her TLCO have also improved without the use of any treatment. And yes, her CT scan certainly isn't normal. There are some improvements, but there are still a significant number of abnormalities. But functionally and physiologically, she was doing really well. So again, what we can see is a disease that, yes, by no means has it all disappeared, but it has got better and it hasn't progressed. This was somebody else. This was another lady who was actually in intensive care and ventilated for 50 days, high pressure ventilation strategy, just because she was so hard to ventilate. So likely to have a significant degree of barotrauma, a lot of ARDS. But she came down to the respiratory high dependency unit, was gave her steroids. This is an overweight lady or diabetes, not ideal. But she got off oxygen. She got off high flow oxygen. Sorry, she went home with nasal prongs and ambulatory oxygen. Then I saw her in my clinic in June, but she was, and as you can see, both FVC and her gas transfer both only 50% predicted, widespread ground glass abnormalities, and not much in the way of kind of fibrotic features, so very little in the way of traction bronchial dilatation. And she was struggling with steroids. She was having mood disturbance. She really didn't like them, and we had, her weight was kind of ballooning. So again, she went through the ILD MDT. This was the first wave. We had no kind of precedent to know what to do, but we decided to give her mycophenolate, and she started on that. And then in October, she had another CT scan. She had repeat lung function, which shows a moderate improvement, at least in FVC. There's certainly the ground glass changes have improved. We continued the mycophenolate for another few months, then stopped it, then repeated the CT scan in February. And I think this does look better. I think it probably looks better than it actually is, just because of the different kind of preparations of the CT scan, and certainly her lung function tests have remained the same then, and we got her off it. But I don't know how much of this would have just gradually over time have got better. The point is, she had treatment, she improved, and no bad came to her, but she does have a lot of persisting abnormalities, but she's doing well. She's back to work. So moving on a little bit to looking at the fibrosis side of things. Well, this is just a list, and a not exhaustive list, of the clinical trials that are ongoing. So a huge number of clinical trials looking for how we can improve post-COVID fibrosis. And I don't want to talk about these in great detail, just because I don't think there's a huge amount of point doing so as things stand without any of the data coming through. But I think what's really important to note is that the outcome measures that these studies are using tend to actually mirror what the outcome measures are for a progressive fibrotic interstitial lung disease, so IPF, or progressive fibrotic ILD. So they look for FVC decline, they look for what here is a disease that we are not seeing as being a progressive disease. So actually, I'm not sure, I'm not convinced in any way that the decline is the right outcome measure to be looking for. Potentially looking for improvement would be probably more, and the acceleration of how quickly it improves is potentially more beneficial, or again, radiologically how things evolve. So I'm not going to, again, focus much on these, other to say that there are 3 clinical trials using nintedanib, there's 2 looking at pirfenidone, there's another one looking at prednisolone, as well as all the other ones. And as you can see, there's a whole range of different protocols. So some of them kind of use them fairly early after COVID, some of them will use them for longer, some of them it's only 8 weeks, some of it is kind of over almost a year. So really wide-ranging studies just to have a look at the kind of role of antifibrotics or immunomodulation in the post-COVID patients. Oh, I think one thing I will say about this is there is one study that actually did get my interest. So as I was mentioning, I think that we see fibrosis developing earlier rather than later. And as all these studies are generally overtaken in the post-acute phase. And that may be appropriate in that, you know, antifibrotic agents are not really tried and tested yet in more the acute phase. But there is one study that I took the slide out just for time reasons, but where they actually gave nintedanib via an NG tube in patients who had severe COVID who were on ventilators. They compared them to a historical group that hadn't had nintedanib as opposed to a placebo group, and their outcome measure was looking at 28-day mortality. Now, they didn't see any change in mortality, but actually the time on the ventilator was significantly reduced. And I think that's actually quite an interesting study. Unfortunately, what they didn't do is look at the CT findings over time and whether the incidence of fibrotic features was less, and hopefully they will do that. But I think potentially if you're going to introduce antifibrotic drugs, there is certainly an argument for doing it earlier rather than later. And then just lastly, so this is an interesting study that has looked at a group of patients who had SARS-CoV-1 in the pandemic of 2003, and it followed them up over a 15-year period. So this was 80 patients. They were all healthcare workers at Peking Hospital, and 71 completed follow-up. So it was a relatively young group of patients. So the majority of them were under 40. So they don't really mirror our post-COVID patients, and a few of them had very few pre-existing comorbidities. But regardless, we have long-term follow-up data, so it's quite interesting. So what the investigators found was over 2/3 of them still had residual interstitial lung abnormalities at 15 years, and about 20% still had some impairment in their gas transfer. I think what's also really interesting is that 96% of them were given methylprednisolone, and so they all had this kind of large dose of steroid, and 20% of them then ended up with a femoral necrosis, head necrosis. So obviously, I think steroid has a role, and that's been proven by the recovery trial, but we do still need to be quite careful about how liberally we give it, because it does have significant side effects. And so this just shows their CT findings, their radiological findings. Well, it doesn't, it shows the extent of the abnormalities. So again, what the investigators did is they graded the CT scores, looking at the different interstitial abnormalities as a percentage of the whole lung. And as you can see, when they were first imaged in 2003, there was a significant amount of ongoing lung injury, but fairly steadily over time, these interstitial lung abnormalities improved and then kind of plateaued in the majority of patients. So although there were some patients where you have ongoing interstitial lung abnormalities, actually again, the majority of those were less than 10% the total lung area. And then as a physician in the long COVID clinic, where we see an awful lot of community patients who never went into hospital with COVID and yet are really battling with the longer term sequelae of COVID, with fatigue and other symptoms that actually don't have any interstitial lung abnormalities. In this group of patients, what the 4-year follow-up study showed was that they didn't get away scot-free. So although respiratory issues weren't such a predominant feature, there was a very high level of anxiety and depression, and over 40% of them got diagnosed with chronic fatigue syndrome using standardized international criteria, and that risk was higher in healthcare workers. So I think really just to summarize, what I'm saying is that yes, we are seeing interstitial lung abnormalities in older patients, particularly those who had more severe disease. Those interstitial abnormalities that can be fibrotic, they can be really quite significant. People do tend to functionally do well, however, and actually a lot of the problems, a lot of the complications that we see in the post-COVID clinic relate to kind of the other wider issues related to having either severe acute infection or even milder infection, and fatigue is a huge problem. And that's it. Any questions? I shall stop sharing.
Thank you, Dr. Fraser, for that excellent overview and the review of the available evidence. There is one question really, but it's on chat, and I may have another question for you. The question is not actually related to ILD. The question is on what's your experience on post-COVID vocal cord dysfunction and laryngeal hypersensitivity?
That's a really good question. And we're not seeing that much vocal cord dysfunction. We are seeing an awful lot. I mean, there is some, but what we're predominantly seeing is breathing pattern disorder. And that tends to be in the non-hospitalized patients who had generally quite a mild illness, who didn't need to come into hospital, who are generally quite fit and well normally, don't have the comorbidities. So a very different cohort from the patients that I've been describing here that end up with interstitial lung abnormalities. We do see some of the patients who've had severe COVID coming through and over time developing this breathing pattern disorder that heightens breathlessness, but not so many, definitely a much smaller proportion than those community patients we see. In terms of vocal cord dysfunction, well, there certainly could be a bit of that, and I think that all often kind of goes part and parcel with the breathing pattern disorder, but actually it tends to be this peculiar kind of apical breathing pattern, which, you know, often people will describe not being able to get a good breath in, not feeling they've got enough oxygen in their system, you know, the really classical kind of symptoms that don't really go with an underlying kind of organic lung abnormality.
Thank you, Dr. Fraser. That has been our experience too, and we have seen quite a number of chronic coughs like sensory neuropathic coughs, dysfunctional breathing, and in instances we have used cardiopulmonary testing to see like quantify their breathing pattern disorders. I have a question from you from Dr. Amila Ratnapal. He has two questions. His first question is already slow. We experience significant proportion of patients with persistent antinuclear antibody positivity in our cohort of patients with post-COVID ILD. Do you consider this group will benefit from early mycophenolate? Basically, he's asking about the autoimmune profile of your patient and whether the autoimmune profile will help you to go for mycophenolate versus antifibrotic agent. Yes.
Yeah, I think that's a tricky one. So I think the problem is that I think we're dealing with a different problem from connective tissue disease associated ILD. And so again, you know, I think when I first started out doing the clinic, I'd quite often do antibody profiles. But actually, like I said, what we see is actually things get better over time rather than worse. And so the role for antifibrotic treatment, which, as you know, slows down fibrosis, it doesn't stop or reverse fibrosis, you know, it's really quite debatable. And I'm pleased these clinical trials are ongoing, but I'm not convinced they're going to yield positive results. And similarly with the kind of like the inflammatory picture, kind of thinking about something like mycophenolate, well, certainly if you think that they have a progressive inflammatory interstitial lung disease that is potentially related to an autoimmune etiology, then yes. But I think if you've got a pure, this is, you know, the abnormalities stemmed from when you first had COVID, and actually over time they get better, then now, as time has gone on, I wouldn't run in and give immunosuppression in this context unless there is evidence of things progressing over time. Or you think that there could be an alternative etiology, such as a connective tissue disease related ILD, and that's why they've got the autoantibodies. So I think it all depends on what you think is driving the abnormalities predominantly. I don't know if that answers the question.
Thank you very much. Yes.
Is the answer.
Yes, another question on whether a combination therapy of antifibrotics or antifibrotics in combination with mycophenolate, what's your experience and that. And there's also a question by Dr. Niranjan who wants to know what features would you favor, what radiological features would you look at when starting on antifibrotic agents as opposed to immunosuppression?
So I think that's kind of, I'm kind of answering the same question again. So I haven't given anybody antifibrotics in my clinic because the criteria, at least in the UK, for antifibrotic therapy is that you've got progression, you've got fibrotic progression. And we're not seeing anybody, or at least I'm not seeing anyone in my clinic with fibrotic progression. So I think that the fibrosis occurs early on in that kind of post-acute but still acute-ish stage. And so I think if you're going to give it, you probably need to give it then. But I wouldn't advocate giving it without there being some kind of clinical trial to back that up, to say this is safe. So we don't do that in our clinical practice. And again, with the longer term immunosuppressants, so I gave one patient mycophenolate after the first wave when we didn't know is what the natural evolution was going to be. And again, now I've seen things evolve, and I've seen that actually over time, things get better. Why not normalizing? They get better. And we still often will see what we kind of, this ground glass change, which seems to be this kind of footprint. Now, whether or not that means fine fibrosis or just static inflammatory change, I don't know, but it doesn't seem to, it just seems to sit there. And so again, giving a drug that, you know, has all sorts of side effects and suppresses the immune system, I'd be really cautious about doing. So I'm really, really conservative. And around the country, I think that's echoed by my colleagues. So I've yet to see a progressive fibrotic coming through. And if I did, I would question whether or not it's related to COVID and whether or not they had an underlying ILD and then got COVID on top of it. Does that, the answer?
So I wouldn't from me. This is what we have found challenging is the patient who had diffuse ground glass changes, whom we couldn't wean off CPAP, who had maybe a pneumomediastinum, and that kind of patients. And the decision to whether to give methylprednisolone or steroids 2 weeks into illness. So we would see in outpatients, by managing these patients on follow-ups, we would see a cohort of patients who have a possible diagnosis of post-COVID organizing pneumonia, who are on steroids. And then we have a more fibrotic group who presents a little later in the disease. So it's always a question whether, if there is a lot of ground glass, whether we should go with the steroids and add mycophenolate, or at what point in time. If we see a lot of traction reticulation, we would favor antifibrotic. Any thoughts on timing of these agents and when you should switch from one to the other?
Yeah, so like that the case I described in widespread ground glass, I think giving steroids is reasonable. Can you hear me? Well, I don't know, because remember that, you know, the mycophenolate often will have, you know, it will take a few months to kick in. So actually the role for it is dubious. So I probably wouldn't. I think probably in the, you know, the clinic stage, if you are seeing ongoing inflammation that isn't shifting, and particularly if you're seeing new infiltrates, and that's a different story. But I wouldn't run to give mycophenolate in the acute setting, because I think it just takes too long to start working. And again, with the antifibrotics, I think you want clinical trials to back up your practice before you know, we're very much bound by guidelines, and so we're not allowed to give them. But you know, I don't know is the answer, because we haven't got any data to say one or the other.
Thank you very much, Dr. Fraser, and thank you for being online with us and answering our questions. It has been a pleasure listening to you. And on behalf of our college and our assembly, our warmest greetings to you and the best of luck.
Great, lovely. All the best now. Thank you.
Thank you very much. So next topic is on progressive fibrosing interstitial lung disease. Our next speaker is Professor Tejaswini Kulkarni from University of Alabama, USA. Currently, she is the Assistant Professor, Department of Medicine, Pulmonology, Allergy and Critical Care Medicine Unit. At present, she is the Director of Interstitial Lung Disease Program. And from 2019 to 2020, she is the Director of Interstitial Lung Disease Clinical Research Unit. And she has a very long CV. Because of the time factor that I have shortened it. And over to you, Professor Teja Kulkarni.
Hello, everyone. I'm Teja Kulkarni, an assistant professor and director of the Interstitial Lung Disease Program at the University of Alabama at Birmingham. Thank you for inviting me to talk at your symposium. Today's talk is on progressive pulmonary fibrosis, the basics and beyond. These are my disclosures. As an outline, we will define what the key and pathophysiological features of progressive pulmonary fibrosis are and understand the comprehensive management of these patients. When we talk about fibrotic lung diseases, they really comprise of a group of almost 200 entities that are characterized by heterogeneity in the extent of inflammation and/or the fibrosis. Now, we know that idiopathic pulmonary fibrosis is the most common form of idiopathic interstitial pneumonias. There is evidence that demonstrate that a similar progressive phenotype can be seen in a proportion of non-IPF fibrosing interstitial lung diseases, And these tend to have a fairly high morbidity and mortality as well. And given that, there has been a new terminology that has recently been defined in the updated guidelines, and it is called progressive pulmonary fibrosis. They do share several overlapping genetic, pathophysiological, and clinical features with idiopathic pulmonary fibrosis, and that is something we will understand as we go through this talk. When we talk about diagnosing fibrotic interstitial lung disease, a comprehensive evaluation is the key. A multidisciplinary team which comprises of pulmonologists, pathology, thoracic radiologists, and sometimes even rheumatologists can really be helpful in the diagnosis of ILD, and the importance of the role of an MDD has been defined over and over in several studies. Now, when we suspect that a patient has ILD, we first think about what is the clinical presentation. Worsening cough, dyspnea and exertion, poor exercise tolerance are some of the features that most patients present with. And then you think about the clinical assessment. The clinical signs of an ILD include auscultatory fine crackles. There can be disease-specific signs, especially if you're thinking about a familial history, familial IPF. There could be early gray hair, or sometimes you can hear inspiratory squeaks with hypersensitivity pneumonitis. And of course, when you think about autoimmune ILDs, you want to think about physical exam signs, which include skin rashes or joint swelling, joint tenderness, mechanics hands, which are classic in myositis patients. Once you have all that and there is a suspicion of ILD, you want to get pulmonary function tests, which typically shows you a restrictive pattern. And then from there on, you want to get a high-resolution CT scan in both inspiratory and expiratory views. Serologies are particularly important, especially when you have a suspicion for an autoimmune ILD. And in the guidelines, it is recommended that you do a comprehensive serological panel in all our patients suspected with ILD. Once you have all that information, you think about the next steps on whether you need to do a BAL, especially if you're thinking about hypersensitivity pneumonitis, and biopsy, whether it is a transbronchial biopsy to look for genomic classifier testing, whether you do surgical lung biopsies, or you do cryobiopsies in centers that have the experience. Once you have all that information, you have either a definitive diagnosis, a working diagnosis, or unclassifiable ILD. And from there on, you want to decide on your treatment. Typically, wait and watch approach is in very small patient population. And then you monitor for disease progression. Now, some patients respond well to treatment and do not really show much disease progression, but there is a group of patients which will show this disease progression, and those are the patients who really are under the progressive pulmonary fibrosis umbrella. The most common of the interstitial lung diseases, of course, this is apart from idiopathic pulmonary fibrosis, which definitely is more of a progressive phenotype. There are others which show a propensity towards having a more progressive phenotype as well. Among the idiopathic ones, you see idiopathic NSIP, PPFE, unclassifiable ILD tend to have a more progressive phenotype. Among the autoimmune ILDs, RA, especially if they have a usual interstitial pneumonia on their CT scan, tend to have a progressive phenotype. The patients with scleroderma, some patients with mixed connective tissue disease have a tendency to have a progressive phenotype. And then finally, there's HB, some of the occupational conditions. Sarcoidosis can also present as a progressive fibrosing phenotype. Why is this happening? What is the pathogenesis? I think it's really important to understand that, to understand how the treatment has evolved for the progressive pulmonary fibrosis. When we think about the pathogenesis, similar to IPF, a hallmark of these diseases really is recurrent or persistent alveolar epithelial injury, which is really happening in the early stages. Now, this injury can be from tobacco smoking, occupational exposures, air pollution, microaspirations, viral infections, or really there could be persistent antigen that is coming in from either exposures, or there's autoimmunity, aging, and genetic predisposition play a role as well. Now, during this process, in this early phase, it can be very disease specific. And that's why it's really important for us to try to identify what type of ILD the patient has. Even if it's all fibrotic, you still want to be able to identify, because in this early phase, really, you might be able to get better response to immunosuppression than you would with the later phase. So in this early phase, again, what you would see is there could be granulomatous inflammation. There's from persistent or unidentified antigen, or from other exposures. In autoimmune conditions, you would see lymphocyte activation and differentiation, and ultimately there is chronic inflammation. Now, this chronic inflammation goes into then the late phase, where really it becomes like a self-perpetuating fibrosis, which is where the pathogenesis is kind of similar to idiopathic pulmonary fibrosis. Now, in this, the hallmark really is a fibroblastic foci, which is seen in usual interstitial pneumonia, and there's essentially lung tissue remodeling and subpleural microscopic honeycomb changes. And that is what would be reflected on your CT scan as well. And once there's this tissue stiffness and the extracellular matrix has been deposited, they upregulate further the profibrotic cytokine pathways, and then there's myofibroblast activation, and then there's just this continuous feedback loop of fibrogenesis. And that's where you start seeing more of the progressive phenotype. And this pathology really is what led to thinking about what are the common mechanisms of the drugs that have worked for idiopathic pulmonary fibrosis. How can that be utilized now in our other fibrotic ILDs? Before we move forward to actually talking about the treatment, let's also talk about risk factors that are associated for the progressive phenotype. Now, as I mentioned, for RA-ILD, a UIP pattern, honeycombing on CT really is a big risk factor, but there are others like male, gender, really in most of the other ILDs. Older age, of course, lower lung function, which is another very common risk factor for progressive phenotype. Identifying these risk factors helps us monitor these patients more closely and enable us to identify progression rather quickly and be able to modify their treatment to help reduce this disease progression. Now, what is progressive pulmonary fibrosis? So finally, let's talk about the definition. In the recent updated guidelines by Dr. Dinesh Raghu and the team of authors really defined progressive pulmonary fibrosis if patients met at least 2 of the 3 criteria. So either there's worsening respiratory symptoms, or there's physiological evidence of disease progression, so which is either an absolute decline in FVC of greater than 5% predicted within 1 year of follow-up, or an absolute decline in DLCO, which is corrected for hemoglobin, it's greater than 10% predicted within 1 year of follow-up. And then the third criteria is radiological evidence of disease progression, which is either there's an increased extent or severity of traction bronchiectasis, there's new ground glass opacity along with areas of fibrosis, along with the traction bronchiectasis. There's new reticulation, increased extent or increased coarseness of the reticular abnormality that you had seen, new or increased honeycomb changes, and then increased lobar volume loss. Now, while we talk about this definition, it's also really critical to make sure you exclude alternative explanations of worsening features. Particularly if DLCO is more, you see more of a decline in DLCO which is not proportionate to the rest of either the FVC or radiological evidence, think about pulmonary hypertension, or are they signs of infection. So you do want to be able to exclude other explanations, but these are the main criteria. Now, PPF is not a diagnosis. It's really agnostic to the underlying condition. It is only really defined to be associated with prognosis. Just a couple of HRCTs as an example. Now in this one, the first one is actually an IPF patient. This is from the guidelines. As you can see here, panel A and B are early CT scans, and C and D are scans done about 4 years later. When you're assessing CT scans, it's done visually. You rely on the percentage of lung volume that contains fibrotic features in the upper, mid, and lower lung zones. And you want to look at both transverse, coronal, and sagittal views. Try to put CT scans next to each other so you can compare them side by side. And you can adjust for lung volume changes if they're done with different protocols. Now, in the early scans, you can see reticulations, you can see some traction bronchiectasis here, and but as you in the next set of CT scan here, you'll see like there's a lot more, of course, reticulations. There's some areas of ground glass in this areas of fibrosis. There's more traction bronchiectasis. Another example is this with an NSIP pattern, a non-specific interstitial pneumonia pattern, where there's ground glass and subpleural sparing that is seen in the earlier scan, but a few years later, there's more of a fibrotic CT scan here. This is very classic for fibrotic NSIP CT scan. And so this clearly changes, which, when you combine with symptoms in pulmonary function tests, it's a progressive pulmonary fibrosis phenotype. So now that you've identified these patients, how do you manage them? And that's really a very complex management plan. When you have patients with autoimmune lung diseases, typically immunosuppression is your first line of treatment. Whereas with patients with chronic hypersensitivity pneumonitis, you really want to work on antigen recognition and eviction. In about 50% of the patients, you may not really be able to identify the antigen, but if you are, then it is really important to try to remove the antigen exposure. And then finally, in idiopathic NSIP, you could consider immunomodulation therapy as well. Once you start these patients with immunomodulators, if they do continue to have a more progressive phenotype, and then we consider antifibrotic therapies, which I will just go into in a minute. If they have stable disease on immunosuppression, then you can just continue to monitor these patients. But in terms of antifibrotic therapy, really, the first study that looked at this was the INBUILD trial. So this was nintedanib in progressive fibrosing interstitial lung disease. It was a 52-week randomized double-blind placebo-controlled trial. The criteria defining entry into this trial were a little bit different than what has been defined in the most recent updated guidelines for PPF. So for this study, patients were included if they had a relative decline in FVC of at least 10% of the predicted value, or they had a relative decline in FVC between 5 and 10%, but additionally had worsening of their respiratory symptoms, or an increased extent of fibrosis on CT scans. Or finally, if they had worsening of respiratory symptoms and an increased extent of fibrosis. The intervention was nintedanib, 150 milligrams twice daily versus placebo, and no background therapy was allowed at randomization. So in this study, there was a adjusted annual rate of change in FVC was the primary endpoint, and as we can see from this figure, patients who were included in the nintedanib group had an FVC decline of 80 ml per year, whereas the placebo group showed a decline of 108 mean annual rate of change in FVC of 187 ml per year. The study was also stratified based on their CT pattern, with the UIP-like fibrotic pattern to a Patients who had a UIP-like pattern on their CT scan benefited from nintedanib treatment as well. The patients did similar to what was seen in the IPF studies. About 67% of the patients reported diarrhea in this study compared to 24% in the placebo group. And the primary endpoint really was reached in predefined subgroups, including autoimmune ILD patients as well. And there are two studies which looked at pirfenidone in patients with either unclassifiable progressive fibrosing ILD, or the other study, the RELIEF study, which I'll talk in the next slide. The first study was a 24-week randomized double-blind placebo-controlled trial where patients were randomized to receive either pirfenidone to 2,403 milligrams daily versus placebo. And 253 patients were enrolled in this study. And as we can see here, the primary endpoint of this study was home spirometry, but unfortunately, because there were so many variations in the measurement of home spirometry, the primary endpoint was not met. The secondary endpoint was to look at site spirometry, and the predicted mean change in FVC by site spirometry was lower in the treatment group compared to the placebo group. Again, similar to what we had seen with IPF, gastrointestinal disorders were higher in the pirfenidone group, but overall it was tolerated well. In the next trial, which looked at pirfenidone in patients with progressive fibrotic interstitial lung disease other than IPF, which is the RELIEF trial, this trial included patients with chronic HP, CTD-related ILD, NSIP, and asbestosis-induced lung fibrosis. It was a 48-week randomized double-blind placebo-controlled trial. The definition of progression in this trial was annual FVC decline of at least 5%, which is based on 3 FVC measurements within 6 to 24 months prior to enrollment. In this study, patients received either pirfenidone 101 milligrams thrice daily, which was up-titrated per protocol, versus placebo, and 127 patients were included in this study. The primary endpoint was an absolute change in FVC of percent predicted from baseline to week 48, and this was lower in the treatment arm compared to the placebo. In view of the premature study termination, though, results must be interpreted with care. Now, the authors, the trial was terminated early because of futility that was triggered by slow recruitment, but imputations were conducted to account for missing data, and so the primary analysis does favor pirfenidone arm. Again, as expected, the most frequent serious adverse events were the infections, which were seen in both groups. The GI side effects were higher in the pirfenidone group. So let me go back again to this slide, which talks about clinical management of patients with progressive pulmonary fibrosis. Now, it is in real world, really, it is hard for us to determine whether, what do you do with the immunosuppression? Do you also escalate immunosuppressive therapy, or do you add on antifibrotic therapy? And that's something we have to take into careful consideration, especially in patients with CTD. You can't really, in all patients, consider taking them off immunosuppression because it might be helping their extrapulmonary symptoms. And so, majority of the times we do recommend continuing immunosuppression if they're able to tolerate it and add antifibrotic therapy. Now, be mindful that a lot of these patients are older and have several comorbidities, so tolerability might be an issue, but with careful monitoring, it is certainly feasible. And then you continue to monitor the patient and see what their response is to immunosuppression versus addition of antifibrotic therapy, and go from there. Now, as I was talking about the management challenges, and these are particularly important in autoimmune ILDs, there's a lot of variability in how these patients present, like what the disease is, what is the pattern of pulmonary involvement. Now, of course, inflammatory and fibrosing abnormalities are more common. That's what we talk about in ILD, but some patients can have airflow limitation. A lot of their symptoms may be driven by pulmonary hypertension. They can have vasculitis. Again, extrapulmonary restriction may happen. So that's why monitoring PFTs every 3 to 6 months can be really helpful. And then in terms of like deciding on that gray zone of immunosuppression, do you escalate immunosuppression if they're on, for example, mycophenolate? Do you escalate that to rituximab or cyclophosphamide, or do you add antifibrotic therapy, or you do both? Really, this is what you do in a multidisciplinary group. Try to discuss what is the CT pattern, what symptoms is the patient presenting with. If there's a lot more ground glass opacities on your CT pattern, that might really reflect a higher degree of cellularity and therefore may be more responsive to immunosuppression. Whereas if it is more of a UIP pattern or very fibrotic CT scan, antifibrotic therapy may be really helpful. So essentially, overall, evaluate the rate of disease progression, severity of the lung disease, what is the underlying condition, and what is the likelihood of response to the medication, as well as tolerability to the medication. Now, I spent a lot of time talking about the pharmacologic therapy, but equally important is a comprehensive management of these patients. Focus on some of the non-pharmacological therapy. Think about symptom relief, supplemental oxygen, really walk tests to assess for need for supplemental oxygen is recommended at least every 6 to 12 months. Pulmonary rehabilitation, there are several studies which have shown the benefit of a good exercise rehab program in these patients. And then finally, if they are eligible for lung transplant and they're continuing to progress in spite of maximum therapy, really consider early lung transplant evaluation. And finally, if all else fails, really we need to focus on our patient, think about early palliative care, symptom relief, how can we make the quality of life for our patients better? So overall, in conclusion, progressive pulmonary fibrosis is a very important characteristic of several of the ILDs, and it's linked with morbidity and mortality. The risk of the progressive nature of the disease and the prognosis really depends on the underlying entity, but it can be variable in a longitudinal disease pattern. Overall, though, we have to focus on the comprehensive management of these patients in reducing symptom burden, morbidity, and mortality. And with that, I'd like to thank you for listening to the talk, and I can take any questions.
Thank you very much, Professor Kulkarni, for that excellent presentation. We have a few questions in the chat box. So one question is, does fibrosis in Cpfv progress routinely, or is the progression is limited?
I think that's an excellent question. When we talk about Cpfv, these patients have both emphysema and pulmonary fibrosis, right? Really, their progression depends on what is the degree of emphysema versus the extent of fibrosis. Patients who have more emphysema may have more progression of DLCO. So studies have shown that if you compare patients with more fibrotic versus more emphysematous disease, the FVC decline may not be similar to what we see in IPF, where it's more of a fibrosis, because the lung volumes don't change as rapidly.
So next question is, what is the place for BAL and cellular analysis in managing patients with PPF and CTD-ILD?
Yeah, so there have been a lot of discussions about doing bronchoalveolar lavage. Now, it has more value in diagnosis, especially when you're considering hypersensitivity pneumonitis as a potential differential diagnosis. Early on in HP, you could see a cellular pattern, there's lymphocyte predominance, and it can be helpful there. Sometimes if you see more of a macrophage predominance, it can help with smoking related, but it's more, the role of BAL is more important in the diagnostic workup rather than, as a evaluation when patients are progressing. Now, if you have a suspicion that they have an infection, there is value in doing a BAL. If patients are on multiple immunosuppression medications, they're at risk for a lot of opportunistic infections. And in those patients, if we do see a lot of ground glass and there's a high suspicion for infection, then we do a bronchoalveolar lavage. But otherwise, there's limited value. It is fairly safe, but there is still a small risk of furthering the disease progression or causing an acute exacerbation in these patients with bronchoalveolar lavage. And so unless there's a high suspicion for infection, we don't really recommend doing that.
Thank you very much. The next question, what are the management options for pleuroparenchymal fibroelastose? What is your experience on that?
Great question, but since it's a fairly rare condition, there's not much data to support, there have not been clinical trials specifically for patients with PPFE. Now, we do see some patients who, even within a cohort of IPF, you may see patients who have more upper lobe dense areas of fibrosis, which can look like PPFE. Overall, if these patients have disease or show disease progression, I would treat them with similar antifibrotic therapies as I would for IPF.
Okay, thank you very much, Professor Kulkarni, for your excellent presentation, and thank you for spending your time with us, valuable time. Thank you very much.
You're welcome. Thank you.
We'll move on to our next presentation. Our next speaker is Dr. Pati Rana. He's board certified in respiratory medicine, currently working as consultant respiratory physician in Trincomalee in the eastern coast of Sri Lanka. He is one of the generation of the dynamic young respiratory physicians. He has been part of a clinical research when he did his overseas training in the Royal Brompton Hospital, Harefield Trust, UK. This was on the MERGE trial, which was a study on energy expenditure and NIV in patients with mild COPD. He has also interest in EBUS TBNA and has had many poster presentations and publications in international fora. It is my pleasure and privilege to introduce Dr. Pati Rana to speak on acute deterioration of interstitial lung disease.
Good evening, everyone. First of all, I must thank the organizing committee for inviting me to talk in this webinar. As you know, interstitial lung diseases are a heterogeneous group of disorders characterized by inflammation and or fibrosis of the pulmonary parenchyma. We heard about the disease trajectory associated with interstitial lung disease in last talk, that is progressive fibrosing interstitial lung disease. Another trajectory is presentation of acute exacerbation in a background of slowly progressive disease. Or else they have acute presentation as the first manifestation of interstitial lung disease. So next 20 minutes, I am going to talk about acute exacerbation of interstitial lung disease. So here we also compare acute exacerbation of ILD, that is AE-ILD hereafter, with acute exacerbation in IPF, that is AE-IPF, as IPF is the prototypical ILD in which AE has been well described. So there are two likely scenarios that the respiratory and also non-respiratory physicians may come across. One is acute respiratory failure in a known patient with interstitial lung disease, or else acute respiratory failure in patient with likely or suspected de novo presentation of an interstitial lung disease. The de novo presentation here is often more difficult to manage because the lack of pre-existing established ILD diagnosis. It makes treatment decisions and judging the prognosis a bit harder. Here, anti-nuclear antibody, extractable nuclear antigen, ANCA would be useful to diagnose idiopathic interstitial pneumonitis with autoimmune features or well-differentiated autoimmune rheumatic disease in the presence or absence of other signs of autoimmune rheumatic disease. Patients with primary respiratory diagnosis of interstitial lung disease without other significant respiratory decompensating comorbidities, they usually present in type 1 respiratory failure rather than hypercapnic type 2 respiratory failure. Clinicians should be wary of the known patient with interstitial lung disease who present in type 2 respiratory failure, they are likely either have a secondary factor contributing to their respiratory failure, for example, obesity, coexisting airway disease like COPD, or fluid overload, or else heart failure. There are 6 main respiratory related diagnoses that may cause decompensation in patients with interstitial lung disease and should be differentiated from true AE-ILD, and we will discuss first those 6. Diagnosing and managing a chest infection is a bread and butter work for the acute intake. In ILD patients, basically we use 2 groups of disease modifying agents like antifibrotic treatment, pirfenidone and nintedanib, and also immunosuppressive therapy including steroids and second-line immunosuppressive medications. Antifibrotic therapy fortunately does not suppress immune system to any significant extent. However, we may consider withdrawing of antifibrotic treatment during acute exacerbation because there might be associated liver derangement, acute kidney injury, nausea, vomiting, or ongoing weight loss. And some of these are side effects of antifibrotic therapy. And the majority of patients, not IPF patients, will be on various doses of oral corticosteroid monotherapy or combination with other second-line immunosuppressive agent. We have to be cautious again, as abrupt withdrawal of prednisolone can push patients into adrenal crisis. However, we may need to withhold second-line immunosuppressive medications if there is a suspicion of an infection. Pneumocystis pneumonia is one of such infection to consider in these patients, especially those who are on corticosteroid more than 40 mg per day, prednisolone, or on dual drug combinations, or patients on IV cyclophosphamide therapy. The radiological pattern in pneumocystis pneumonia infection may vary. There may be a rather non-specific ground glass or acute pneumonitis-like changes or centrilobular nodules. This can make it difficult to discriminate pneumocystis infection from acute exacerbation of ILD and also from other pneumonitis like viral infection. And relevant microbiological samples need to be sent early in hospital admission to differentiate these infections from other causes. And so left-hand side, you can see this is ground glass opacities leading to Cpfv pattern in a confirmed patient with pneumocystis pneumonia. And right-hand side, again, predominant nodular adhesion, again, a patient confirmed to have pneumocystis pneumonia. Infection evaluation could be carried out with initial white cell count, C-reactive protein, procalcitonin, etc. Even though all these are non-specific investigations. Again, procalcitonin guided antibiotic treatment or clinician determined antibiotic treatment. These are associated with similar mortality, but if we guide antibiotic therapy with procalcitonin, there might be reduced exposure to antibiotic in this group. So in addition to routine blood and sputum cultures, other microbiological sampling, including acid-fast bacilli, streptococcal and legionella urinary antigen, nasal, sputum, or tracheal aspirate for viral PCR, pneumocystis, and herpes simplex virus infection could be taken where relevant. And we may withhold second-line immunosuppressive medication and start broad-spectrum antibiotics. Microbiological sampling of the airways using bronchoscopy would be another option. The problem with this technique is that the difficulty and it is potentially dangerous in acutely hypoxic patients, but may be appropriate later. And also another drawback is low positive yield in bronchoscopy in this type of cases. This lady had post-COVID interstitial lung disease, was under my care, and after discharge, she again readmitted with worsening of respiratory failure. And there was, in addition to ground glass opacity and consolidation, suspicious of bronchus intermediate obstruction, therefore proceeded with bronchoscopy, which showed a yellow color mass-like lesion. The biopsy confirmed it is Aspergillus infection. So that is why in selected cases we can do bronchoscopy as well to arrive at the final diagnosis. Secondly, we should consider heart failure because, again, another very common problem. So distinguishing pulmonary edema from interstitial lung disease on a chest X-ray sometimes be challenging, especially acute little patients, X-ray taken in the emergency department with portable machine, AP view. Therefore, a history of ischemic heart disease, history of heart failure, and previous echocardiographic review would be useful to arrive at a diagnosis. So while awaiting these investigations like biomarkers and also BNP, if we have uncertainty, we can try a dose of intravenous diuretic, provided the blood pressure and the renal function permit, with careful assessment of the response, and this approach may be reasonable. And again, pulmonary hypertension, secondary to interstitial lung disease, is a frequent comorbidity and of concern because its presence is a strong predictor of mortality. And these patients also can develop physiologically compromising right ventricular dysfunction and present with sudden breathlessness. Thirdly, we should consider acute pulmonary embolism because these patients are most of the time older patients, especially IPF patients, and they are less mobile with multiple comorbidities. And IPF itself is a procoagulant condition, therefore increased risk of venous thromboembolism and pulmonary embolism. CT pulmonary angiogram is the investigation of choice because ventilation perfusion scans are often difficult to interpret in the setting of background fibrosis. And then, so we consider infection, heart failure, and pulmonary embolism. Then we should think about pneumothorax as well. Cystic interstitial lung diseases like lymphangioliomyomatosis, Langerhans histiocytosis, so well known to present with acute pneumothorax. And patients with other interstitial lung diseases also in whom emphysema coexist also can have pneumothorax, and any other interstitial lung diseases also can complicate the picture with pneumothorax. This young lady came to us with a pneumothorax, previously undiagnosed interstitial lung disease, and found to have multiple cysts bilaterally. And we thought of lymphangioliomyomatosis and referred for surgical lung biopsy as there was no angiomyolipoma in the abdominal scan. While awaiting the surgery, she developed again large pneumothorax in the opposite side as well. Ultimately, we confirmed the diagnosis as LAM. And again, this lady, this is a lady with again interstitial pneumonitis with autoimmune features. She was quite stable with steroid and second line immunosuppressive therapy. Again, admitted with sudden worsening of breathlessness, found to have clinically subcutaneous emphysema, and CT scan confirmed pneumomediastinum as well. Patients with IPF are often male and old, and they have a significant history of smoking. Therefore, there is increased risk of developing lung cancer mounting to 7 to 20%. They can develop any type of cancer, but commonly adenocarcinoma and squamous cell carcinoma and located periphery. Those are the mostly fibrotic area. And this man was in our care with idiopathic pulmonary fibrosis on antifibrotic medication. And he came to clinic with worsening of breathlessness, found to have right paratracheal opacity, and there was a skin nodule. FNAC of this nodule confirmed the diagnosis of lung cancer. And the sixth one is the drug-induced interstitial lung disease. DMARDs are commonly used to treat rheumatoid arthritis, and acute pneumonitis, although rare, is the most common lung complication related to the use of conventional synthetic DMARDs. MTX-related pneumonitis is not associated with development of RA-ILD, and results also indicate that methotrexate use is not associated with the occurrence of AE-ILD as well. But leflunomide, an alternative to MTX, has been linked to development or worsening of underlying RA-ILD and also acute presentation. So once all others are considered, remaining one is acute exacerbation of interstitial lung disease. So idiopathic pulmonary fibrosis acute exacerbation has been described in 2006 as previous or concurrent diagnosis of IPF and worsening breathlessness within 30 days, and CT scan showing new ground glass or new consolidations. And there should not be evidence of pulmonary infection, and we should exclude other causes like left heart failure. And evaluation of samples should include studies for routine bacterial organisms, opportunistic organisms, and common viral pathogens to exclude pulmonary infection. Although this proposed definition represented a major achievement in AE-IPF diagnosis, it was difficult to apply in clinical practice, mainly because of the challenge of excluding all potential known causes of acute respiratory failure. Considering the difficulty in classifying AE-IF using the proposed criteria and the statement that idiopathic AE-IPF might be indistinguishable both clinically and prognostically from that induced by known causes of acute lung injury such as infection, an expert working group was encouraged to revise the previous AE-IPF definition with the aim of updating the diagnostic criteria. So therefore facilitating application in clinical practice. Here they have removed those exclusion and instead of that included deterioration not fully explained by cardiac failure or fluid overload. Acute exacerbation of ILD is not exclusively restricted to IPF, but it also occurs in other interstitial lung disease as well, such as autoimmune rheumatic disease diagnosed patients with ILD. So therefore they don't have still criteria, and therefore they have proposed the criteria. They included rheumatic disease with previous or concurrent diagnosis of ILD. And also another consideration in this type of patient is drug-induced interstitial lung disease. So this slide shows ground glass changes during acute exacerbation in a patient with interstitial lung disease. So in a patient with acute respiratory failure related to interstitial lung disease, we should consider all those factors which need specific treatment, and at the same time, we should keep the patient safe with oxygen support or the respiratory support. We have several options, including oxygen therapy, high flow nasal cannula, non-invasive ventilations, and also ultimately invasive mechanical ventilation. It is important to optimize oxygen therapy early. This will often help relieve the significant breathlessness that patients with ILD experience. The longer the patient remains hypoxemic, the harder they must work to maintain their oxygen saturations, and the more fatigue and distress they will become. So clinicians should aim for target saturation of 94% to 98%, and it should be close to 98% actually. So if available, some patients may gain comfort and symptom relief from high flow nasal oxygen. The evidence based to support the routine use of CPAP in this setting is currently lacking, and however be considered in individual cases the trial for patients' compliance and usefulness after appropriate assessment by a respiratory physician and or intensivist. When a physician or intensivist encounters a deteriorating patient with acute exacerbation of ILD, the decision for invasive mechanical ventilation must be balanced with the prognosis and reversibility of the patient's condition. This is a study done between 2006 to 2012. The mortality associated in these patients who underwent invasive mechanical ventilation was 58.4% during 2006, and it was 49% in 2012. So studies have shown that subset of patients can be weaned from mechanical ventilation and discharged, suggesting that IMV should not be systematically denied to these patients, but considered individually. AEILD has some parallels with ARDS, both from a clinical and also pathological background. Similar to ARDS, patients with AEILD are prone to ventilator-induced lung injury. Thus, mechanical ventilation strategies used in ARDS should be reasonably utilized in patients with AEILD as well. Then disease-specific treatment to control inflammation and autoimmunity are considered, like glucocorticoids and second-line immunosuppressive medications. Some other measures, including immunoglobulin, plasma exchange, etc., have been used with variable success. The PANTHER-IPF study stable IPF patient and has shown that prednisolone azathioprine combination is harmful in this population. And also COPD patients also, we don't use long-term systemic corticosteroid, but we use them during acute exacerbation with good success in outcome. Similarly, we can consider systemic glucocorticoids during acute exacerbation of IPF as well. The jury remains out as to whether a high dose, low dose, or no dose of steroid is effective at changing the poor outcome of an AE-IPF. So therefore, no particular corticosteroid formulation has been found preferable over another, despite good outcomes with dexamethasone in ARDS and COVID-19 associated lung injury. So this is a study done again in IPF patients during acute exacerbation. They have prescribed IV methylprednisolone 10 mg per kg per day 3 doses, and also IV cyclophosphamide pulse therapy. So they have found that in patients with AE-IPF, adding intravenous cyclophosphamide pulses to glucocorticoid increased 3-month mortality. These findings provide evidence against the use of IV cyclophosphamide in such patients. So therefore, mounting evidence is pushing clinicians away from an aggressive immunosuppressive approach in AE-IPF. Most authors favor a low dose of steroid approach, 30 mg per day for 10 to 14 days, even though some authors favor high dose of pulse methylprednisolone therapy. There is less evidence to guide management in non-IPF fibrotic ILDs, and good clinical judgment is needed to select the best management approach, including an assessment of how much of the patient's disease is clearly fibrotic versus inflammatory, as there can often be some overlap, but with one pattern is predominating. So withdrawal of DMARDs is often the first step in therapeutic strategy in autoimmune rheumatic disease when they present with AE-ILD, and aggressive dual immunosuppression is more likely to have an impact on improving outcome of the AE event associated with autoimmune rheumatic disease. So we can try high-dose IV methylprednisolone therapy and also cyclophosphamide pulse therapy and rituximab, depending on the previous exposure. And finally, palliative care should be considered early in the patient's admission, and eligibility of patients for lung transplant should play an important role in the management decision tree in countries where an active transplant program is going on. So in summary, known patients or the first presentation of acute respiratory failure suspected as having ILD, and we should exclude those potential causes like chest infection, pulmonary embolism, pneumothorax, heart failure. And if it is, we should manage accordingly. Otherwise, we should proceed with HRCT showing new ground glass opacity or consolidation. And then if it is acute exacerbation, should manage accordingly. Thank you very much.
Sarcoidosis exacerbations coming with aspergillus has been a significant infective agent. There are no questions on chat. So can I ask you one question about the role of biomarkers like KL6 and the role of KL6 in IPF exacerbations and other interstitial lung disease? Are there any potential biomarkers that could detect?
Yes, sir. Thank you very much for the question. Yes, these biomarkers are extensively studied to detect the acute exacerbation and also to assess the prognosis of these patients. But these are not routinely practiced in clinical setup, and most of the time these are under investigation.
Okay. So KL6, is it in all IPF or interstitial lung disease, or is it particularly in idiopathic pulmonary fibrosis? As you said, they are in research stages and not in clinical practice.
Yes, so that is not quite sure, sir.
Okay. Thank you very much then. Thank you very much again, once more. Thank you.
Next, we have two case discussions. This will be done by our senior registrars from National Hospital Sri Lanka and National Hospital for Respiratory Disease, Valisara. We have an expert panel for this purpose. Let me introduce the expert panel. Dr. Amita Fernando, Senior Consultant Respiratory Physician, National Hospital. Dr. Saman Kulratna, Senior Consultant Respiratory Physician, National Hospital for Respiratory Diseases, Valisara. And Dr. M. Adhavan, Consultant Respiratory Physician from Teaching Hospital, Jaffna. And Dr. Sumudhu Palihawardena, Consultant Radiologist, National Hospital for Respiratory Diseases, Valisara. And Dr. Ramani Punchiheva, Consultant Pathologist from National Hospital for Respiratory Diseases, Valisara. The first case will be discussed by Dr. Madhushankar Ratnayaka from National Hospital, Sri Lanka. This is regarding connective tissue disease associated interstitial lung disease, a disease in evaluation. So over to you, Madhushankar.
Yeah, good evening. Can you see my presentation?
Yes, we can see.
Yeah. So we'll discuss the first case in our panel discussion. It would be connective tissue diseases related ILD, a disease in evolution. So let's move on to our case. Let's move on. Sorry for the delay. Our patient is a 33-year-old medical officer who was previously well. Actually, he presented in 2016 with the complaint of a chronic cough for 9 months and dyspnea and reflux symptoms for 6 months. His cough was dry in nature and it was associated with a progressive worsening dyspnea with a MMRC grade of 3. Yeah, in the history, he denied any associated hemoptysis, constitutional symptoms, wheezing. There were no upper respiratory symptoms such as postnasal drip or headache, and there was no chest pain or associated features of heart failure. There was no evidence of dysphagia or dinophagia, and there was no history of past history or contact history of tuberculosis. He denied recurrent sinopulmonary infections in his history, and there were no connective tissue disease features such as polyarthritis, skin rash, Raynaud's phenomenon, or proximal muscle weakness. However, he was a keen pigeon breeder about few years ago when he presented, but he did not have other organic or inorganic substance exposures. On examination, it was basically a normal physical examination where it was negative for palo, icterus, clubbing, lymphadenopathy, or any connective tissue disease stigmata, such as skin rash, inflammatory polyarthritis, oral ulcers, proximal myopathy, pinched nose, microstomia, sclerodactyly, Raynaud's phenomenon, nail fold infarcts, or digital tip pitted scars. Systemic examination, including the respiratory and cardiovascular system, were unremarkable. With related to initial blood biochemistry, the full blood count as well as the inflammatory markers, including the CRP and ESR, were within normal limits. Sputum AFB3 samples were negative, and the chest X-ray was reported as normal. And 2D echocardiogram at baseline was normal without evidence of pulmonary hypertension. However, upper GI endoscopy revealed severe gastroesophageal reflux disease with esophagitis. His 6-minute walking test did not reveal any exertional desaturation, and he walked up to 520 meters. Initially, this patient was managed as a cough variant asthma. However, he had very minimum response to a course of systemic and inhaled steroids. And his GORD was managed with double dose proton pump inhibitors and prokinetics with a poor response. The evaluation continues with a pulmonary function test. Pulmonary function test reveals there is a restrictive defect. Then further evaluation with related to connective tissue disease screening, including antinuclear antibodies, rheumatoid factor, ENA panel, and ANCAS, all were negative. Total serum immunoglobulin E, Aspergillus specific immunoglobulin E, as well as the allergen specific panel were negative. The skin prick test for common allergens such as house dust mite and cockroach and etc. were also negative. With related to the allergen specific IgE panel, apart from moderate to low intensity significant allergy for soya bean and grass mixture, others were having a negative result. This is the HRCT, which was done in 2017. Okay, it shows predominantly centrilobular ground glass density intensities, basically predominantly involved in the middle and lower zones. However, there was no air trapping or mosaicism, and there were no features to suggest underlying fibrosis. He underwent a bronchoscopy and a bronchoalveolar lavage, which revealed a lymphocytic pleocytosis with a lymphocyte percentage of 30%. Subsequently, he was managed as a case of non-fibrotic hypersensitivity pneumonitis and commenced on prednisolone 35 milligrams daily dose for 2 months, followed up with a tapering off. However, after 4 months, his 6-minute walking test, lung function test, HRCT, and symptoms did not have any interval worsening or improvement. So he underwent a VATS biopsy. He underwent a left-sided lingular lobe biopsy, where the histology revealed lung parenchyma with peribronchial accentuation of interstitial inflammatory changes. Interstitium shows a mild to moderate infiltration of lymphocytes, plasma cells, and epithelioid histiocytes. Very occasional aggregates forming non-caseating granulomata are also noted. Fibrosis is very minimal. Alveolar spaces are irregular and mostly narrowed with empty spaces. Occasional aggregates of interstitial lymphocytes are also noted. The visceral pleura is unremarkable. There is no evidence of caseation or malignancy. So the conclusion was a case of hypersensitivity pneumonitis. So it was diagnosed as a steroid refractory non-fibrotic hypersensitivity pneumonitis, and mycophenolate mofetil was commenced. From 2016 until 2020, he was continued on MMF with prednisolone. However, this patient symptomatically as well as objectively from lung function test and the HRCT remained static. So this is the lung function which has been done in 2022 January, where if you compare with the previous lung functions, there is a drop in the forced vital capacity, which is of more than 10%. However, repeat DLCO could not be performed because the patient could not adhere to the correct technique of performing DLCO. This diagram shows the progressive reduction in his the FVC and FEV1. So this is a simpler version of the summary of his FEV1 and FVC in liters, which happened over time. As you can see, it remained almost static until 2021, where there is a significant decline in 2022. So with that, the HRCT was repeated. Okay, the radiological evidence is suggestive of progression of the underlying disease. A decision was taken to seek an opinion from a radiologist in India. According to him, it was a fibrosing ILD, which is seen showing features characteristic of a fibrotic, non-specific interstitial pneumonia pattern, which is likely due to an underlying connective tissue disease. There are subtle, ill-defined distal bronchocentric opacities that may suggest the presence of associated follicular bronchiolitis. These findings are not suggestive of hypersensitivity pneumonitis. So he suggested an aggressive evaluation for an underlying etiology like connective tissue disease. The low attenuation areas within the reticular opacities suggest the possibility of scleroderma or scleroderma overlap or a vasculitis with the overlap. So the autoimmune panel was repeated in 2022, which revealed a positive ANA in a titer of 1 in 100 with a nucleolar pattern. Anti-SCL70 antibody was positive. However, rest of the ENA panel was negative. The repeat 2D echo remained normal without evidence of pulmonary hypertension. 24-hour pH monitoring was done and it revealed there was a severe esophageal dysmotility. So a final diagnosis of systemic sclerosis, sign scleroderma, was made in the backgrounds of positive ANA in a nucleolar pattern and interstitial lung fibrosis and esophageal dysmotility. Our patient was managed with escalation of the mycophenolate dose up to 2 grams daily with the PCP prophylaxis with cotrimoxazole and prednisolone 15 milligrams every other day. And perfenidone was commenced as for a case of progressive fibrosing ILD. Then he was referred to the GI surgeon for an opinion on Nissen's fundoplication, which deemed not necessary at the moment. So with this, we come to an end of our case presentation and it's time for the panel discussion.
Shall we move on to the questions? Or?
Yes, sir. So my first question goes to Dr. Amita Fernando. Sir, this patient has been managed as hypersensitivity pneumonitis at the outset. So how certain are we regarding the diagnosis of hypersensitivity pneumonitis at the outset in this patient?
Thank you, Madhushankar, for that interesting presentation and the very comprehensive data that you presented. Answer to a question, initially this patient had an exposure history to pigeons some time back, prompting us to think of a diagnosis of hypersensitive pneumonitis. And the HRCT showed centrotubular ground glass densities with subpleural sparing, with no air trapping or mosaicism that we tend to associate with the cellular type of hypersensitive pneumonitis. But the distribution of these nodules, which we would expect to be more of upper lobe distribution, was not there in this patient, and it was mostly a mid and lower lobe distribution. Subsequently, the BAL analysis showed I think macrophages of around 60%, and there was some doubt whether this would be a really representative BAL sample, and the lymphocytes I think was 30%. When I spoke to Dr. Adhavan, I think he will tell us later some of the details that that's available to him. Flow cytometry was attempted in this patient, but because of non-standardization, it was very difficult to get a proper flow cytometry done. And as one of the speakers mentioned earlier, from the Dr. Kulkarni about the role of BAL being more diagnostic in connective tissue ILD exacerbations than in monitoring progression. So if we had access to CD4-CD8 ratios in this patient, maybe it would have been helpful. Then as we progressed, the spirometry, I don't recall whether there was any small airway involvement. Was there predominant small airway involvement in these patients, in which lead us to suspect a small airway disease like HP or follicular bronchiolitis?
Yeah, initially, sir, there was small airway involvement as well. However, the reversibility tests were not performed due to patients' poor techniques.
So the other thing is the histology, where it clearly stated that the histology, the VATS biopsy, this is a VATS biopsy, mind you, a surgical biopsy, which showed non-case-hitting granuloma and some histiocytes. I think Dr. Ramani will speak to us a little later in more detail about this. So that actually favored a hypersensitive pneumonitis. If you looking back and thinking that this patient is a connective tissue ILD, then we would tend to think that these centrilobular ground glass densities subsequently evolving into a more ground glass densities with some degree of traction later on, and some low attenuation areas, as you mentioned, which the Indian radiologist has mentioned. If you look at this, whether this could possibly be hypersensitive, this could be a follicular bronchiolitis at the outset and not hypersensitive pneumonitis. In favor is your distribution, in which you said that distribution was also mid and lower load distribution, with absence of any constrictive bronchiolitis, because there was no air trapping, no mosaicism in this patient. So that would suggest bronchiolitis. But then if it was a follicular bronchiolitis like a BALT or bronchial lymphoid associated proliferation, you would expect a more lymphocytic thing and not histiocytes, macrophages, things. Then you'll see there was a few germinal centers, or in that report you said a few lymphoid follicles, no?
Yes, sir.
The predominant feature was granulomas, which were of non-case-hitting type with histiocytes. So Dr. Ramani may speak in detail. So I think it's a open question, because we cannot favor one or the other. But I think looking at how the disease progressed subsequently, and the ANA positivity and SCL positivity, we have to think of a connective tissue related ILD. But we would find, and if it was like a cellular NSIP, then you may be able to explain your granulomas and the histology, but you would not be able to explain your centrilobular ground glass density nodules, which is predominantly a feature of hypersensitive pneumonitis, or in this context, a follicular bronchiolitis. So I would think that it is still debatable, and we can argue on the point, but I think either it's two pathologies or it's one pathology which is in evolution, as your case illustrates. So anyway, when it comes to management, the decisions that we have to take is antifibrotics or upscaling your immunotherapy. So that would depend on the subsequent findings of a more fibrotic NSIP.
Amita, was there any esophageal dilatation in the HRCT?
There was no. Madhushankar, can you answer that?
Yes, sir. He didn't have any esophageal dilatation in the CT.
But he had significant reflux symptoms,
yes,
and there was fund duplication was considered. That is also one feature that we look for, esophageal dilatation. I think the patient had pH monitoring and things, no?
Yes, sir.
Thanks.
So thank you very much, sir. The next question is for Dr. Ramani Punchiheva. Madam, is this patient's pathology of VATS biopsy consistent with HP. Since CTD-related follicular bronchiolitis is being considered in this patient, is this patient's histology report consistent with a possibility of follicular bronchiolitis?
Histologically, actually, I received the wedge resection of the lingular lobe of the left side. And it's a representative histological sample. And microscopically, it was the centrilobular accentuation of inflammatory cells mainly within the interstitium. It was a mild to moderate amount of lymphocytes, plasma cells, epithelioid histiocytes, and few vague, ill-defined granulomas, right? And other than this ill-defined granulomas, epithelioid histiocytes were prominent. And other than this inflammatory infiltrate, there were few lymphoid follicles, but those are lymphoid aggregates, actually, not the follicles. No germinal centers. But basic histopathological conclusion was granulomatous interstitial lung disease. So with the history of pigeon exposure and the radiological suspicions for a hypersensitivity, my diagnosis also was hypersensitive pneumonitis. But in connective disease ILDs, you don't get any granulomas actually. And even for these follicular bronchiolitis, you have to have some well-formed lymphoid aggregates, especially with these germinal centers. But none of them were seen in this biopsy at the onset of the biopsy interpretation. So my final diagnosis was at that time, it's a granulomatous interstitial lung disease favoring hypersensitive pneumonitis.
Okay, thank you, madam. I have another question.
Madhushanka, just one point.
Yes.
The panel that you presented, the antigen panel was mainly a IgE panel. We
Yes,
would
sir.
do precipitins and IgG on this. Can you clarify whether subsequently this patient had the IgGs done for antigen exposures? Maybe Dr. Adhavan can answer that.
Yes, sir.
Yes, sir. He also had undergone IgG for pigeon dropping, droppings and the feather antigens. So both were turned negative. So he had IgGs for pigeon droppings as well as feather antigens. Both were turned negative. Can you hear me, sir?
Yeah, can hear. Thank you, Adhavan. We can move on, Madhushanka.
Yeah, one more question, madam.
Yeah.
What is the place of bronchoalveolar lavage in this patient for flow cytometry?
Right. Actually, flow cytometry, for the indication of flow cytometry, you should have an adequate number of inflammatories, especially the lymphocytes. If you don't have much adequate number of lymphocytes, it's the procedure is failed. Actually, so in that time, I can remember that this was the lesser number of lymphocytes. But in cases like hypersensitivity, you can do the flow cytometry, but it is not diagnostic because usually in HP, flow cytometry reveals the low CD4 to CD8 ratio, but sometimes you can have increased level of CD4 to CD8 ratio as in sarcoidosis. So it is not very conclusive in HP, but you can do for the HP.
Ramani, if I can ask a question, in follicular bronchiolitis, is it more the germinal centers, are they more B lymphocytes or T lymphocytes?
In this B lymphocytes, but for the other way, this lip lymphocytic interstitial pneumonia, you get more the T cells. That means CD3 mark, 3 cell T markers, but B in the follicular bronchiolitis.
Right. Thank you.
Okay.
Okay, thank you very much, madam. My next question goes to Dr. Sumudu Paligavatna. Madam, looking at the serial HRCTs, what do you think about progression of this patient's disease?
Madhushanka, can you hear me?
Yes, madam.
Okay, I'm not going to on my video because I'm in the middle of a power cut, so you won't see anything in the background. So I have gone through the 2 series of images, but since they are not the proper DICOM images and coming with a lot of artifacts, for me, there is no gross progression. But actually, like, you know, looking very closer, there could be a very mild element of progression of bronchiolectasis along the bases. But otherwise, the rest of the inflammation, which is the predominant HRCT finding that we see there is a ground glass. So they have remained stable, except for a very mild element of progression of bronchiolectasis along the bases, which may suggest setting up of some fibrosis. So that's the only thing that I could appreciate in the given images. The rest was stable.
Okay, that's thank you, madam. That leads to my second question. Does this patient have cellular HP, which is steroid resistant, or is there any evidence of to suggest a fibrotic element also?
Yeah, whenever that you see bronchiolectasis, intralabial interstitial thickening, whatever lines and bands that you see are an indication of fibrosis. So whenever you see traction bronchiolectasis, that means the bronchi are being dragged by something in the periphery. So that's fibrosis. So the reason that we look for fibrosis, traction bronchiolectasis, is to see whether there is fibrosis also going on, not only acute inflammation. So in this patient also, we could appreciate a small element of fibrosis in both the series, and there is subtle progression in the current series of images.
Okay, thank you very much, madam. Last question. The HRCT report from India says, I'm quoting, the low attenuation areas within reticular opacities suggest the possibility of scleroderma or scleroderma overlap or vasculitis overlap syndrome. Do you agree with this, or is it due to mosaics?
I mean, to be honest, I could not I cannot comment on that, because one thing is I'm not the images are not optimal. So I wonder what he was referring to actually. He would have seen something much better than what we are seeing. So I don't want to comment on it actually. If we had proper images, we can review and see what he was referring to. But by looking at the images given to us, I cannot comment, to be honest.
Okay, right. Thank you very much.
Madhushanka, if I can just when you put those images outside the ground glass areas, there are blackish areas. There are blackish areas without normal lung tissue. I was discussing with with Dr. Adhavan, and Dr. Adhavan was speaking thinking whether this could be a possibility of emphysema. We have seen in COVID patients with advanced fibrotic disease where there is alveolar rupture and air tracking along the interstitium, giving rise to pneumomediastinum and things. So I wonder whether these changes could represent the low attenuation area that the Indian radiologist is speaking of, whether it could represent some interstitial emphysema, air in the interstitium, because he's strongly favoring a fibrotic process. I wonder whether these low attenuation areas could be interstitial emphysema due to alveolar rupture and air leakage into the interstitium.
No, actually, those are no interstitial. There is no interstitial emphysema. If you are referring to the lucencies that we see in the upper zones, they are emphysema.
Yes, that's what I was thinking. Not in the Sumudu, not in the areas where there is ground glass and traction. Yeah. In the areas outside it, there are black areas. I was wondering
those are emphysema. Yeah, those are emphysema.
Yeah, I was wondering whether this when the Indian radiologist is referring to this, whether this could be emphysema rather than mosaic areas.
Yeah, those are centrilobular emphysema actually.
Okay, thank you very much.
Okay, now we will
one more comment about this low attenuation area. So that I did a literature search on these low attenuation areas associated with scleroderma ILD. So what they, as Amit sir mentioned, they mentioned that is more common in smokers than the non-smokers, and it is more common in the males. And what they say is actually the emphysematous changes. So I think that images are not clear to you as I have sent a video image rather than a Google Drive image. So yeah, so it is actually an emphysema, what is mentioned in the literature.
Okay, thank you very much, sir. So my next question goes to Dr. Adhavan. Sir, with the current available evidence and positive SCL70 and ANA of a nucleolar pattern, would you favor a diagnosis of CTD-ILD? If so, is it a single pathology or two different pathologies in the same patient?
Yes, it is controversial. However, I believe the unifying diagnosis, the unifying clinico-pathological radiological diagnosis in this patient is likely a CTD-ILD due to scleroderma, sinus scleroderma. The first thing is that imaging is mostly suggestive of a fibrotic NSID because there is a clear basal predominance of the abnormalities, as well as Madam Sumit said, there are traction bronchiolactasis. So this more favors rather than upper predominant abnormalities, there is a basal predominance of these abnormalities. Second thing is that he has clinical severe GORD symptoms, and this is translated in the GI physiological studies with 24-hour pH monitoring and esophageal mammometry, showing evidence of severe GORD and esophageal dysmotility. Third thing is there are serological markers for scleroderma were positive, both ANA and anti-SCL70 were positive. So, I understand that the opinion of Madam Ramani Pujeva, that she mentioned there is very bronchial accentuation of the inflammations and the presence of non-caseating granuloma, which is not common feature of the CTD-ILD. However, this has been mentioned as a minor findings in patients with fibrotic NSID as well. So, though it is debatable, my unifying diagnosis would be scleroderma ILD.
Thank you very much, sir. My second question is, in spite of almost static lung functions without developing complications such as pulmonary hypertension, this patient had no radiological resolution. In fact, there is interval progression. How should we approach to this sort of a case?
Yes, so if you look at this pulmonary function test and the HRCT, and so his pulmonary function test has been quite stable from 2016 to 2020, but from 2021 to 22, there is a significant decline of the pulmonary function test as evidenced by 10% decline in the FVC. And there is evidence of radiological progression. So it is a progressive ILD rather than a static or a burned out ILD. So I think this is the point that we need to intervene.
Okay. So my third question is, in spite of significant dyspepsia and reflux on 24-hour pH monitoring, would you be concerned regarding the absence of esophageal dilatation on serial HRCTs?
Yes, so the symptoms of GORD and the evidence of the physiological evidence of gastroesophageal reflux disease are demonstrated in approximately 90% of the patient with scleroderma. Out of these individuals, the esophageal dilatation is seen in 80%. Though it is seen in majority of the patients, though esophageal dilatation is seen in majority of the patients, but it is not a must finding. It may not be seen in 20%.
Okay, thank you very much, sir. My last question. In conclusion, what is your approach to final management of this patient? Is it immunomodulatory therapy or antifibrotic therapy?
Yeah, so if you discuss about the immunomodulatory therapy, so this is a scleroderma ILD, and this comes under extensive disease because there is more than 20% involvement on the HRCT. So it could be considered an extensive disease. And in addition, their FVC is clearly below 70% from the outset. So therefore, the immunosuppressive therapy is clearly indicated. So there are two large randomized control studies compared the use of cyclophosphamide, MMF, and the placebo. So it was clearly shown from the scleroderma lung study 1 and 2, the cyclophosphamide and the MMF are superior to placebo. And when the MMF was compared with the cyclophosphamide, the MMF was found to be non-inferior to cyclophosphamide in preventing the decline of the lung function. However, the MMF is found to have a superior side effect profile compared to the cyclophosphamide. So therefore, my first choice of immunosuppression would be MMF. Though this patient has been treated with MMF in the past, the doses has been suboptimal as for an HP. So I would optimize the dose of the mycophenolate to 2 grams to 3 grams daily. And as a remission induction therapies, which should be continued for 24 months, unless he develops progression of disease despite being on MMF, or if he develops any adverse reactions to MMF.
Okay, thank you very much, sir. This brings the end of first case panel discussion.
Okay, thank you very much, Dr. Madhushankar Ratnayaka and the experts on that panel discussion. And also, it was nice to see the consultant launch at Teaching Hospital Jaffna, refreshing my memories as well. And next case presentation by Dr. E.G.H.D. Silva from the National Hospital for Respiratory Diseases, Valisera. The topic is recurrent hypersensitive pneumonitis, perspectives in diagnosis and management. Over to you, Dr. Silva.
Thank you, sir. Can you see my slides?
Yeah, I can see very well.
I'll be discussing a case of recurrent hypersensitivity pneumonitis, perspectives in diagnosis and management. So our patient is a 52-year-old housewife with 1 child who was previously unevaluated, and she presented to us with progressive exertional dyspnea, MMRC grade 1 for 3 months duration. This was associated with non-productive cough and loss of appetite. She didn't have any associated fever or loss of weight.
Can I interrupt? Can you do a slideshow?
So can you, is it better now?
That's better, yeah.
Yes. Okay, so I'll begin again. So it's a 52-year-old housewife with 1 child who presented to us with progressive exertional dyspnea, MMRC grade 1 for 3 months duration. She had associated non-productive cough and loss of appetite. There was no wheezing, loss of weight or fever, and the patient didn't have a past history of bronchial asthma or COPD. She didn't have a past history of any cardiac illness, and there were no features of heart failure. She had a significant exposure to poultry because her neighbor was a chicken rearer, and there was an exposure to 20 to 30 birds, and there was a very short distance of less than 20 feet. This exposure had been present for more than 1 year duration. Apart from that, there was also an exposure to passive smoking, and there was no other identifiable exposures to organic or inorganic substances. The patient didn't have any features of connective tissue disorders, and she didn't have an exposure to any long-term drugs. Her past medical history, surgical history, family history, and gynecological history was unremarkable. Moving on to examination, her BMI was 23 kilograms per meter square. She was afebrile and not cyanosed, and there was no evidence of clubbing or any features of CTDs. She was dyspneic with a respiratory rate of 24 cycles per minute, and she had bibasal fine end inspiratory crepitations. There were no rhonchi or evidence of effusions. She didn't have any evidence of pulmonary hypertension or heart failure. An abdominal and neurological examination was unremarkable. With this, we went into the evaluation of the patient, and her resting saturation was 95 with an ABG showing evidence of type 1 respiratory failure. The 6-minute walk test showed a significant exertional desaturation from 95 to 70% with a reduction in the distance. Full blood count, CRP, ESR, liver functions, and renal functions were unremarkable, and ECGs and 2D echoes didn't show any evidence of heart failure. Rheumatoid factor and ANA titer was also negative. This is the patient's chest radiograph. I'd like to invite Dr. Sumudu to discuss the radiological imaging.
Okay, Heshini. Can you hear me?
Yes, madam.
Yeah, so the chest X-ray shows some very subtle coarsening of the interstitial markings bilaterally, predominantly in the mid and basal lungs. There are no discrete lesions, opacities, collapse consolidations, and there's subtle increase in density in the central lungs. So based on these appearances, this is very non-specific. If we are provided the history of all what Heshini was describing, then we can raise the possibility of hypersensitivity pneumonitis in this case, or otherwise it will come with a host of other differentials, which would include hypersensitive pneumonitis as well. The others would include pneumocystic carinae pneumonia, non-specific infections like mycoplasma, and sometimes early pulmonary hemorrhage as well. Yeah, over to you, Heshini.
So we went ahead with the HRCT.
Okay, I'm going to share my screen. Okay, so this is what we saw. So I'm starting from the APCs. So what we are seeing is very ill-defined ground glass nodules, closely packed with areas of lobular air trapping. And if you look closely, you should be able to appreciate this ill-defined ground glass nodules, sparing the base, sparing the pleura. There are no pleural base nodules here. And when we go to the bases, there are more and more lobular air trapping, and the appearance is called head cheese appearance. So radiologically, this is a typical case of subacute hypersensitivity pneumonitis. Okay, over to you, Heshini.
Thank you, madam. So following the HRCT, we went ahead with the lung function test. And as you can see, the FeV1 to FVC ratio was 0.96 with a reduced FVC of 41% with a reduced DLC of 50%. There was no significant post-bronchodilator response. With this, we went ahead with the bronchoscopy and bronchoalveolar lavage. And the bronchoscopy did not show any endobronchial lesions. And the bronchoalveolar lavage showed 810 cells, of which 45% were lymphocytes. The pyogenic, fungal, and TB cultures were negative. So in the diagnosis of hypersensitive pneumonitis, you start off with a patient who has a history and chest X-ray suggestive of hypersensitive pneumonitis, and then you have to follow up with the exposure assessment and perform a HRCT chest. With that, a bronchoalveolar lavage and lymphocyte cellular analysis needs to be performed. And if there are typical exposures with typical HRCT findings and bowel lymphocytosis, following a multidisciplinary discussion, a diagnosis of HP can be confirmed. However, if the typical findings are not available following the multidisciplinary discussion, it can be decided to either go ahead with a surgical lung biopsy or a transbronchial lung cryobiopsy. So considering our patient, she had an identified antigen exposure to poultry, and she had compatible HRCT findings with central lobular nodules, mosaicism, air trapping, and patchy ground glass opacities. And she had a bile lymphocytosis of more than 30%. And with this, we confirmed a diagnosis of HP without going into a biopsy. Considering the classification of hypersensitive pneumonitis, previously this disease was classified based on the duration, and it was classified as either acute, subacute, or chronic. However, now it is said that we need to classify patients based on the presence or absence of fibrosis. So the patients can be either cellular HP or fibrotic HP, and our patient fell into the group of cellular hypersensitivity pneumonitis. So we treated this patient with avoidance of the exposure, which is the mainstay in treating hypersensitive pneumonitis. And it is said that even with an extensive history, up to 60% of the exposures cannot be identified. Extensive questionnaires have been implicated in the evaluation of HP, and serum IgGs also have a place. However, in certain cases, this cannot differentiate between sensitization and disease. Inhalation challenge can also be used, and this is highly specific and sensitive for HP, but can only be performed at expert centers. Avoidance of smoking has an effect in the treatment of HP, because tobacco smoking has an impact on the immune reactivity of patients, as well as it drives the pathogenetic process towards a fibrotic disease. The main pharmacological treatment that is used is systemic corticosteroids, and our patient was also treated with oral prednisolone, and this was gradually tailed off. So HP initially responds to corticosteroids. However, there's little evidence on the use of corticosteroids in the long-term management of hypersensitive pneumonitis. The other immunosuppressive agents which can be used are MMF, azathioprine, and rituximab. However, there is no clear evidence that has been found through RCTs. So following treatment, we repeated the HRCTs. Madam, over to you.
Do you want to share the screen and go ahead?
Madam, I am sharing the screen.
Okay, right. So in the follow-up CT, we could see near complete disappearance of the ground glass nodules. So indicative of good response to treatment. So here, like when you compare it, you can see the density of the parenchyma is less, and you don't see that ground glassy ill-defined central lobular appearance, and even the air trapping, it's not appreciable in the images that Tejaswini is showing us. Anyway, in the proper study also, there were no significant residual disease initially. Over to you, Tejaswini.
Thank you, madam. So we followed up with the lung function test, and as you can see, there was an improvement in the FVC from 41% to 53% following treatment, and there was a significant improvement in DLCO also from 50% to 69%. The 6-minute walk test also showed a significant improvement, and there was no exertional desaturation. Following this acute episode, unfortunately, the patient defaulted treatment for more than 2 years, and she presented to us again recently with exertional dyspnea, MMRC grade 2 for 3 months duration. There were no associated constitutional symptoms. And on extended history, it was revealed that the cages that were used for chicken rearing were still persistent at the premises. Examination did not reveal any cyanosis or clubbing. The patient was dyspneic with a respiratory rate of 18 cycles per minute, and there was evidence of bibasal end inspiratory crepitations. ABG showed evidence of type 1 respiratory failure, and there was a exertional desaturation on the 6-minute walk test from 97 to 92%. FOB was repeated, and this showed 200 cells with 15% of them being lymphocytes. The lung functions were also done, and it showed an FVC of 50% and a DLCO of 42%, both of which were reduced. This is the HRCT which was repeated at the second presentation. Madam, would you like to comment on this?
Yeah, okay, so the follow-up HRCT, the APCs show the setting on of early fibrosis. If you look at the pleura, you can see the irregular pleuroparenchymal interfaces and some interlobular interstitial thickening, right? And if you can go to the bases, Hashini, do you have any images? Right.
Yes, ma'am.
In the bases, you may see that there's some residual ground glass and some areas of lobular air trapping, but the background interstitium shows some distortion or early coarsening. So this shows the setting of early fibrosis, including the APCs. So not only the bases, even the APCs are involved. So this means progressive hypersensitive pneumonitis with setting on of early fibrosis. And even the bases, you can see some bronchi which are seen within 2 centimeters from the pleura, which is indicative of early traction bronchiectasis. Yeah, over to you, Heshini.
Thank you, madam. So with these findings, we be discussing the management of recurrent hypersensitive pneumonitis. Sir, Dr. Saman Kulratna, would you like to let us know how we should tackle this problem?
Yeah, thanks, Heshini. In fact, we just presented this case to highlight the practical problems in the diagnosis and the management of hypersensitive pneumonitis. Now we know the hypersensitive pneumonitis is a complex heterogeneous ILD that occur when susceptible individuals develop an exaggerated immune response to an inhaled antigen. So previously, this was classified as acute, subacute, and chronic. But the presentation of hypersensitive pneumonitis is very much variable. Some have self-limiting disease with some inflammatory response, and some present with relapsing cause, and some can have progressive disease ending up with pulmonary fibrosis. In acute presentation, we know that when there is exposure to a high amount of antigens, the patients will develop flu-like illnesses. And most of the time in our setup, we don't see these acute hypersensitive pneumonitis patients. So because the reason may be they may be presenting to our medical units or some acute ETUs. So we usually don't see these acute presentations, those who come with hypoxia, flu-like symptoms. And if somebody, pay some attention for this exposure history, may have done these X-rays and the HRCT to confirm acute presentation. But normally we don't see acute HP cases. But in chronic disease, it is due to a low grade of exposure to low amount of antigens, maybe continuous exposure or recurrent exposure, later progressing into the chronic disease. So in our patient, in fact, she presented with acute, the subacute kind of presentation, and responded very well to the treatment. And later on, we can follow up this patient, maybe because of the COVID epidemic during last 2 periods. But finally, when she came this time, she showed some HRCT evidence of early fibrosis, which is supposed to be a bad prognostic feature. So it is important to assess the exposure in these patients and to address that. And sometimes in the history, you might not, in more than 50% of cases, apparently you can't find an exact cause. And some of the patients may have more than one the causative agents for them to develop this hypersensitive pneumonitis. So it is very, very important to arrange follow-up. This is what has happened in our case. Over to you, Heishini, to discuss the management options available.
Thank you, sir. So considering our patient, we stressed on the proper avoidance of exposure and we treated her with systemic corticosteroids. Apart from that, for the management of fibrotic HP, there are different drugs which are available, which are antifibrotics. And the main two agents are nintedanib and pirfenidone. And considering nintedanib, it has been studied in the inbuilt trial, which was a trial which assessed patients with progressive fibrosing ILD other than IPF. And in this trial, 26 of the patients had fibrotic HP. And this drug showed a reduction in the rate of decline of FVC by 57% over 52 weeks. Apart from that, the risk of acute exacerbations as well as death was reduced. So pirfenidone is the drug which is more commonly available in Sri Lanka, and there are no RCCTs that are available for pirfenidone, and there is some conflicting evidence in different studies. Of note is the RELIEF study, which was previously discussed by Dr. Kulkarni. And as she mentioned, 57 of the patients had hypersensitive pneumonitis, and over 48 weeks, there was a significant difference in the rate of decline of FVC. The other treatment options that are available for the management of HP are long-term oxygen therapy, ambulatory oxygen, pulmonary rehabilitation, vaccinations, and the management of common comorbidities, of note GORD and COPD. So considering the prognosis of patients with hypersensitive pneumonitis, there are different factors, including intrinsic factors, exposures, physiological factors, radiological features, and histological factors, which may implicate or worsen the prognosis. Sir, would you like to comment on the prognosis in relation to our patient?
In fact, this patient has had further exposure. Although she is a female patient, she has developed the progressive fibrosis in the second presentation, so which shows some poor prognosis, and there is decline in FVC, low DLCA, all suggestive of poor prognosis. And so that's the main thing. Main thing is the presence of fibrosis in this second HRCT. Yeah. So with this case, I would like to suggest certain things. One is when we diagnose hypersensitive pneumonitis, HV patients, how to do the assessment of exposures. So we are not doing home visits. Like in the case of management of TB, whether any possibility of getting our PHIs or public health nurses to do home visits and give them a checklist and give them some knowledge on HP and to assess whether they have got any exposures, because a lot of our people, a lot of our patients, they don't come out with the exposure. And even though sometimes, even if you find these exposures, and they might not, they might not remove their chicken, they might not remove their birds from the house. So I think I would like to suggest whether we could get the help of the public health sector to address these patients with hypersensitive pneumonitis.
Thank you, sir. So these are my references, and this concludes my case discussion.
Thank you very much, Dr. Heishani and the team for that excellent case presentation. Now we have come to the conclusion of an excellent webinar on interstitial lung disease. Firstly, I would like to thank all the speakers, including our international speakers, Dr. Emily Fraser, Professor Teja Kulkarni, and Dr. Pati Rana, and also to our expert panel, Dr. Amita Fernando, Dr. Saman Kularatna, Dr. Sumudu Palikavadna, and Dr. Ramani Puncheva. Also, my thanks goes to Senior Registrars, Dr. Madhushankar Ratnayaka and Dr. A. Shanti De Silva for excellent case presentation. And very special thanks to the President of the Sri Lanka College of Pulmonologists, Dr. Ravani Karunathilaka. And also, I appreciate the help of our Interstitial Lung Diseases Assembly. Special thanks goes to Dr. Amila Ratnapala, Dr. Pati Rana, and Dr. Damit Rodrigo for excellent hard work and coordination of speakers. So thank you all. And also very big thanks to the sponsors, Cipla Pharmaceuticals, for sponsoring this webinar. And also thanks to Nalina and the technical support team. Thank you very much. We are looking forward to continue these sort of webinars frequently and keep in touch with us with the Sri Lanka College of Pulmonologists. Thank you very much.